For the selection of patients with FARAPULSE, the strategy now is to perform all first-line ablation with FARAPULSE. Only isolation of the pulmonary vein after, if it's necessary, after the blanking period or 6 months period, we start with other procedure like alcoholization of Marshall vein or something like that. But in first line, we use only FARAPULSE with paroxystic. It's quite enough, and with persistent AF, sometimes it's enough. So we decide to do this kind of strategy.
Yes, in particular persistent AFib patients with a complex substrate that we had the difficulties to treat with RF, especially posterior wall that is very difficult to isolate. In these patients with FARAPULSE, we are observing good outcomes.
And with the FARAPULSE system, PVI are performed a bit widely, so but antrally to the veins, which is most probably the best answer we can give if we do only PVI to paroxysmal but also persistent patients.
I would say that every patient with paroxysmal AF or patient who has to receive PVI isolation are really good candidates for PFA ablation. In the future, maybe persistent AF with posterior wall isolation, this has to be proven, but they could probably also benefit from the PFA ablation.
The FARAPULSE has permitted us to enlarge the spectrum of patients affected by atrial fibrillation from paroxysmal to long-standing persistence. Again, because of its safety, because of its efficacy, and again, in our lab we are concentrating in using this technology in patients that have failed on cardioversions, so patients that are extremely, sick from a rhythmic point of view, and have seen that with FARAPULSE, by ablating also beyond the PVs, we have a conversion rate which is extremely high.
Yes, I do believe. FARAPULSE is really helping us to isolate PVs in a safe and effective way. So we see that we're moving from patients with proximal AFib to more persistent AFib. Also because we have the possibility to isolate the posterior wall in a very safe and once more effective way.
You can use FARAPULSE both in patients with paroxysmal and persistent atrial fibrillation, but I think with FARAPULSE it's easier to target additional structures beyond PVIs.
Treating all patients that need a first PVI procedure with FARAPULSE, paroxysmal and persistent patients. So I think it's performing a good PVI, and a good PVI is the cornerstone of any AF treatment.
Now with the FARAPULSE, especially if you would try to go a bit beyond PVI, like posterior wall ablation, we know it's an easy procedure. We can do it from the first procedure, for example, we start with a PVI plus posterior wall. It's a very short procedure, it's a safe procedure. So I'm seeing my daily practice that we are going further. I mean, we don't have so many DUPs in persistent patients. And even in elderly patients, I feel safe to use it in elderly patients because this patient has no symptoms after the ablation.
Using FARAPULSE in pure paroxysmal AFib patients, but as we found that the procedures are reproducible, easy and fast, and the catheter is quite versatile, we're expanding to almost any patient with atrial fibrillation as a first procedure.